survival of these transplant patients. We at Mankind, and here we are having a very specific division, that is Transplant Mankind, with its legacy brands such as Pangraph, Mycept, and Penimal Viral. We are very much committed for our transplant patients, how with the help of those brands we can have good quality of life for these transplant patients. So I will not take much time, and now I would like to request Dr. Subho Banerjee for further proceedings. Thank you.
So thank you, Dr. Rahul. And as you know, Mankind is actually a co-sponsor of this, is a sponsor of this immunology course. So now we are at the fifth webinar, and this is to be delivered by none other than our Secretary of ISOT, Dr. Manish Balwani. So as you know, we have covered the initial basics like the overview and a few other tests like CDC, flow cross matches, and HLA typing. So if all of you are following the webinar schedule, so the next topic is HLA antibody testing and its use and how to start HLA antibody testing at a new center. So this is of very key importance for everybody to understand, and these are the areas now where now everybody who is doing a transplant are putting in their minds into this, and there is a little bit of confusion. So I'm very sure Dr. Manish Balwani is the most eligible person to be speaking on this, and I'm sure he has is going to present a lot of important understanding key points and data. And once we have the webinar in schedule, so in any case there is a question that comes to your mind, please feel to share those questions so that we can take them up in the later part of the program. Over to Dr. Manish Balwani, sir.
So I would like to thank Dr. Subho Banerjee, ISOT Executive Council, to give me this opportunity to speak on immunology topic of antibody profiling and how to start antibody profile at new center. So I am going to just touch upon what are the various HLA antibody profile tests which we commonly do, what is the indication, and we will just share a single case about interpretation. So these are the few commercially available beads which we use. So on the left side, we can see there is a pooled antigen bead. Here the antigen density is low, as on one bead we have multiple antigens, maybe around 10 to 14. And these antigens are derived from 3 to 5 individuals. And the important point to mention here is antigen density is low. As antigen density is low, sometimes even if the antibody is present, it may not react. And sometimes it can be falsely negative. So that is the limitation with this. Then there is, which one we have is a phenotypic bead. It is used for the PRA quantitative testing. Here, the important difference is it has a bit of better resolution as compared to qualitative test like pooled antigen bead, which we just discussed. And here we have the complete class 1 and class 2 antigens are derived from only single individual. When it comes to single antigen bead, here its specificity is high, resolution is good. The density of antigen on bead is actually high, and this antigen is derived from the cell line. So this is the basic characteristic of the antibody profile test which we have available. To discuss something about the concept, so we can see on the left side that there is a bead. This bead is 6.5 micron thick, so it is actually very small, and this bead is impregnated with the dye, that is phycoerythrin. Now on the right side we can see that this is the bead. On the bead we have a small antigen. If the antibody against this antigen is present in the sera of the patient, it will react with it Once there is the antigen-antibody reaction, this phycoerythrin anti-IgG body will bind to this and will give rise to fluorescence. Now, in the Luminex machine, there are two lasers which we can see here on the right side. This is the red laser, this is green laser. This red laser identifies the bead number where the reaction, antigen-antibody reaction has happened. This green laser will identify the exact antigen on which the antibody has bound. So this is the basic concept of single antigen bead assay, how the Luminex works. To speak further in detail about mixed IgG antibody screening, so here we can see there is a single bead. On this single bead, there are multiple loci phenotype and antigens. So to just see an example, in this bead, we have A2, 11, 24, 80, 4 antigens of B, 3 antigens of C. So this is a screening test. It cannot be used to determine the specificity or to identify the DSA. If this bead shows positive fluorescence in the machine, it means that any one of these antigens or more than one of these antigens has some kind of antibody uh, against these antigens, positive or present in the serum of the patient. But you cannot tell against which antigen this reaction is happening. So it is non-specific. That's why it is used mainly for screening. Now, this is PRA quantitative testing against class 1 and class 1. The difference, as we already discussed, here the beads contain antigen from single phenotype. Here also, each bead has multiple antigens, but lesser than the screening one. So here, just to give an example, on one bead, we have 6 antigens, 2 from A, 2 from B, 2 from C. Here, the result will be given as a percentage and the positivity. So positive or negative, if positive, what is the percentage of PRA? So here also, if the bead shows fluorescence, it is positive. You cannot tell that which antigen among all these 6 is giving rise to positive antigen antibody reaction. It is mainly used as in the organ allocation, that how much PRA is positive, and different states have different criteria and different points allocated to particular percentage of PRA. About single antigen, here we can see one bead contains, so each bead contains single antigen. So this is the bead, there is single antigen, and the technology through which these antigens are derived are cell derived. We will see further in the coming slides. So to just discuss more about the mixed antibody qualitative screening, here the results are given as positive or negative. In the machine, there is a software. Uh, the software here gives the results as positive and negative, not only based on MFI. There is also an inbuilt NBG ratio where it is seen as positive or negative. To mention, and I will request our clinicians to interact more closely with the lab personals who are sitting in the immunology lab, because sometimes you get results like this. So we got the patient's result like this, class 1 and class 2 negative. And when we asked them that please share with us the chart, here we came to know that the positive control was low. So this test is invalid. So you should check what is the positive control, what is the negative control. Positive control should be at least 4 to 5 times of the negative control. In most of the cases, it is actually more than 10 to 20 times of the negative control. So this test result was invalid. This is the repeat test of the same patient. Here you can see the positive control is 13,670 and the negative control is somewhat 09.30. So the ratio is more and this result is valid. Now this qualitative, to just give an example, when we put a cursor on some bead, on one bar we can see this bead is containing this number of antigens. This is how you can come to know these are the antigens present on that particular bead. Now, to give an example, this is the HLA typing of patient and donor. Patient is daughter, donor is mother. The mismatched donor antigens I have highlighted: A33, B40O1, that is B60, C34, DQA131. And this was the PRA screen of this particular patient. We can see on the left side bottom that positive control is higher, is proper, and it's more than 4 times of the negative control. And here we can see that in general, after looking at it, there are certain bars which are red in both class 1 and class 2. So this is positive overall. But you can see in the software, there is a option of find antigen. Here what we did, we just saw the mismatch antigens, and when we put A33 in this column, we can see that A33 is mostly represented on the negative, that is the green bars. So there is no A33, and we cross-checked by putting this cursor on each of the red diagrams that there was no A33 present in the red diagram. Then there was B40, that is B60. B40 has two split antigens, 60 and 61. So when we put B40 here, it is showing that B60 is on the negative diagram, that is the green bars, and B61 is on the red bar. So we went back and saw which B40 does this patient have. So it was B60. So we saw B60, that is this B60 was on the negative, that is the green bars only. Then C3, this C3 bead was not present in the present screening kit. So what is the end result of class 1? Though it was positive in general sense, but it is negative for this donor, as donor antigen was represented for class for HLA A and B. So further testing for this patient with DSA with class 1 single antigen bead can be avoided if there is no history of pregnancy, history of sensitization, blood transfusion, we all know, like and previous transplantation. About C, no comments can be made as this was not represented on the screening panel bead. Regarding class 2, so only mismatch antigen was DQ3. When we saw DQ3 in the screening panel, it has again the split antigens of 7, 8, 9. All were on the negative side, that is the greener side of the bar diagram. Again, what is the end result? Though the class 2 was positive in the general sense, but negative for this donor, as donor antigens were represented on the negative beads. Further testing with SAP class 2 can be avoided if there is no previous history of sensitization. It holds true in maximum cases. The pitfall with this testing is this screening bead has the antigen representation, the density of antigen on this screening panel is low. So sometimes there can be issue, but if overall it is green, 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 and there is no previous history of sensitization, then you can fairly consider that there is no further testing, need of testing with the class 1 and class 2 single antigen bead. About single antigen bead test, We all know it is more sensitive, specific, and it can be done in 3 to 6 hours. So it's possible you can get the results even in case of cadaveric transplant. There you can test 3 to 4, maybe more than that, patients' serum samples simultaneously. So it is a better test. If it is available and affordable, we should go ahead with the single antigen bead analysis. What we expect from SAB, we uh, want to know whether the antibody is donor specific. If possible, we want to quantify it. It also helps in predicting the positive flow and CDC crossmatch. If there is, it can predict also the chances of ABMR or graft loss. Sometimes it correlates with the effectiveness. We can see how much the anti-rejection therapy has reduced the particular antibody against the antigen, donor antigen. The issue with SAB testing is not all the HLA antigens are represented on class 1 and class 2. If a person has the donor from the ethnical minority, so the donor's antigen may not be represented on the SAB kit. In such cases, epitope knowledge sometimes helps in predicting the positivity to non-represented alleles. So as we all know, there is a cross-reactivity among HLA antibodies. It is mostly due to the sharing of the public epitopes. It is mostly useful in case of HLA DP beta 1. For example, in case of HLA DP beta 1, the non-tested antigens like DP beta 1 2, 24, 40, they share the epitope like P56A and P85 with the beads of DP antigen like 4, 15, and 23. So if beads like DPB1 of 4, 15, and 23 are positive, so it can be predicted that the non-tested antigens like 2, 24, and 40 may have the positive antibodies against these antigens. This Craig pattern, that is the epitope sharing pattern, is commonly available on the net. Here I am showcasing the zero pattern of the Craig. Similarly, there is the DNA pattern of Craig, and we can understand the epitope sharing by going through this Craig pattern. There are a few challenges in the SAP testing. Sometimes we see that the non-HLA antibodies can interfere with the SAP testing. So these immunoglobulins like IVIG or recent history of infection or inflammation give rise to certain antibodies in the patient serum, and those antibodies can bind to these beads of the single antigen and falsely give rise to high MFI. So there are such, then again here it becomes important that you are regularly interacting with your lab personnel. Like you can tell them the patient has recently received the IVIG, or patient may have the recent history of infection. So that is a clue for them. And for them, they can see that the beads with patient's own antigen also have the high MFI. Usually the patient's own antigen do not have the high MFI. They usually do not produce MFI. So if against own antigen, they are getting high MFI, then we should be suspicious that there is the non-specific immunoglobulin binding. There are certain situations where we see false negative DSA scenario. Why it happens? So there is a phenomena called distributive strength of antibody. This phenomena is more common for HLA antigens which share the public epitope. We all know that the public epitope is shared among the HLA antigens, while private epitope is specific for particular antigen. The commonly known antigens which share public epitope are BW4, BW6, and DR52. So we call these as the broad antigens. If this phenomenon of distributive strength of antibody is not recognized, sometimes we may see acute antibody mediated rejection. So to discuss it in further detail, when a single epitope is shared by multiple antigens, so the complementary antibody will be spread over a large number of beads on the SAB assay. So the MFI for all those antigens where this antibody is distributed will be less, and maybe it it may be the below the particular level. Say for example, if the cutoff of that particular lab is 1,000, and if you have an antibody which is spread over shared public epitopes, and it is shared in 5 to 6 antigens, so maybe the strength of antibody will be less than 1,000, maybe 800, 900, 700, 600, like that. And but in reality, to that particular epitope, the strength of MMI is actually high. So sometimes in these cases, we may see, even if the screening or the SAB profile was negative, but you may see the rejection in the first week or first 2 weeks of transplant. So to understand it is very, very important. To understand the concept of shared epitopes is actually important. So on the left side, we can see these are the private epitope. To further understand in a better way, here the MFI to a particular B18 epitope. Here the antibody has bound is binding to B18, and the MFI strength is 12,000. This is private epitope. Each antigen has his own epitope, and that is private. And the reaction here is coming around 12,000. Say for example, these are sharing the common epitope. Here the strength of antibody will be distributed. Here we can see on the left side the antibody is bound only to B18 and B18. It is not binding to B35, B7, as it is binding to private epitope. But if these three are sharing the common epitope, then the antibody will bind to all. We can see it has bound to B7, B18, and B35. And thus here the strength of antibody is reduced. B7, B18, and B35, the strength is 4,000, 4,000, 4,000. It was just to give you an example. Now, here you can see that on the left side, the maximum MFI to particular DR antigens is less than 540. So, the result here which we may give, the lab personnel may give, if they are not provided with proper history, that there is MFI is less than 500, it may not be clinically relevant, and the result can be given as negative. The same patient after infection, this is one of the example I am quoting here. The response here we can see after infection, there is the memory response. Here the antibody which is shared among the common group DR 8, 11, 12, 13, 14, 17, 18. These all antigens are sharing the common antibody. If there is only one DR13 bead in the panel, the MFI, this would have been higher even on the left side. See what has happened, what we mean to say. On the left side, these antigens 8, 11, 12, 13, 14, 17, and 18. These are sharing the common epitope, and this public epitope sharing has decreased the antibody strength, which if only single antigen would have been present here in the panel, the MFI would have been much higher. The same patient after transplant, after infection, is producing this kind of memory response. And now we can see that all the antibody strength is much higher because of memory response. Now there is a thing called Prozone phenomena. What is Prozone? If the antibody present in the sera is excessive, it will saturate the binding sites of anti-IgG detection reagent as all sites are saturated, it will prevent the formation of detectable phycoerythrin complexes. So in this scenario, as there is increased presence of donor specific antibody, but as it has saturated all the binding sites, it will give rise to false negative result. Usually we see this kind of Prozone phenomena in highly sensitized patients. So if there is a history of sensitization, one should always keep this scenario in his mind. How to suspect this? So whenever you are getting a flow cross match positive, even a mild positive, so you should be, and if the patient has a history of sensitization, you should think that there is a possibility of Prozone phenomena. So there is a way to treat it. We can retest the same sample with the diluted plasma. So it can be diluted with the help of EDTA or DTT in a 1:10, and then we have to retest it. Now, to see another example of Prozone, here on the left side of the bar diagram, we are seeing this DQ7. This antibody to DQ7, this is the DSA, that is this antigen is the donor antigen, DQ7. This sera was treated with the EDTA, and when EDTA was this was treated, we can see the MFI against DQ7 is actually much higher. Here it was in the range of DQ7 was in the range of maximum was up to 13,000. But here after EDTA treatment, the strength of antibody we can see it is around 24,000. So whenever you are getting flow cross-match positive, CDC positive, but negative DSA, just think that the patient may be having Prozone phenomena in the SAP testing. About epitope analysis, it will be covered in the future webinars. Now, what is the utility of these testings? It can help us in predicting the flow cross-match positivity. This virtual cross-match gives us advantage in better allocation, in better organ allocation. So this was published by Dr. A.K. Baranwal in IJMR in Feb 17. This slide and research by Baranwal shows that their flow cross-match was T-cell flow cross-match was positive when the average MFI as per SAP in Luminex was 3000, and their CDC came positive when the MFI in the Luminex was 7000. So this SAB is too sensitive. The flow cross-match will become positive, was positive for Dr. Baranwal when the MFI was 3000, and CDC was positive when the MFI was 7000. This is the slide from Peter Morris, 8th edition kidney transplant. Here, as we can see the immunological risk as high, intermediate, low, and standard. So if CDC is positive, we all know the risk is high. If CDC, along with CDC, flow cross-match, if CDC is positive, we expect that flow and Luminex single antigen bead will be positive. The risk is low when CDC is negative, but flow and Luminex SAB is positive. The risk is low when the CDC and flow cross-match are negative, but positive with the Luminex. And the risk is standard when the CDC flow cross-match. So I'm sorry, here there's a mistake. It is negative. The flow is negative, CDC is negative, and on the Luminex, it is MFI is the highest MFI is less than 500. Now, what does the presence of pre-transplant DNA, uh, what does it, what is the correlation we can say of pre-transplant DSA and allograft survival? So this paper was published in Journal of American Society of Nephrology 2021. Here, what they did, they saw the relative risk of acute antibody-mediated rejection as per the MFI. So here, if the MFI was less than 460, the relative risk was 1. As the MFI was increasing, we can see the relative risk of AMR was increasing. So the highest relative risk, if the MFI was more than 6,000, DSA was around 113. The presence of DSA as the MFI increases, the relative risk of acute antibody-mediated rejection also increases. This paper in Journal of American Society of Nephrology 2023 also showed that though there was a negative cross-match, if the patient had donor-specific antibody, there are increased chances of antibody-mediated rejection. Similarly, there is increased risk of graft failure. It was highlighted in the same paper. Increased risk of graft failure with presence of DSA, though flow cross-match was negative. Now, we need to understand whether all DSAs are equal. Sometimes we see, even though the DSA is present at a higher level of MFI, but they do not cause ABMR, and sometimes at the lower level of MFI, they cause the ABMR. We need to understand it. So it depends on multiple factors, whether the presence of DSA will lead to rejection or not. It depends on the pre-transplant history, like history of sensitization, whether the preformed DSA, preformed antibody is donor specific or not. And also post-transplant, there are certain factors that the level of antibody present in the sera, patient sera, and whether it is complement binding or not, and whether the antibody which is present in the patient does it belong to IgG1, G3 or G2, G4, and what is its affinity. So these are the multiple factors which determine the incidence of rejection. So there is nowadays more stress on the C1q positivity, which we will discuss in the coming slides. So if the antibody which is detected, the titer is high, we can to certain extent understand by doing C1q anti-HLA antibody profiling whether the antibody present in the sera is complement binding or not. If it is complement binding, then the chances of rejections are high and the kidney allograft survival is less. What is IgG subclass and what are the chances of complement activation? So we can see here the highest complement activating capacity is of IgG3, but the abundance of IgG3 in sera is less. For IgG1, it is abundantly present and it has got good complement activating capacity. IgG2 and G4, though present, have got less complement activating capacity. IgG4 has no complement activating capacity. Now, there is certain role of DSA in the diagnosis of AMR. DSA and MFI do not reliably predict the severity of pathology. The DSA and MFI at rejection diagnosis do not reliably predict the responsiveness to treatment also. But there are certain papers which have shown that if there is antibody against DQ, they usually correlate with late rejections and they are also less responsive to treatment. The role of DSA in antibody monitoring can be to some extent used to see the response to treatment. Normally, we do not chase the level of antibody after treatment. We usually see the clinical response like improvement in urine output, stabilization of creatinine, improvement of creatinine, and the clinical improvement. We do not always chase it with the antibody level. Sometimes we see many cases where the creatinine has come down, but the DSA present in the serum is at a higher level. So it may not correlate, the MFI may not correlate in all cases clinically. Just we discussed that the MFI is not actually the antibody strength. So what should be the ideal MFI cutoff? It depends and varies from lab to lab. It needs to be modified as we just discussed earlier. Sometimes patients has the history of sensitization. The epitopes are shared, private public epitopes, and the distributive strength of due to distributive strength of antibody, you may have the result of MFI as the less than the your lab's cutoff. So there are multiple things which should be considered while deciding the MFI. This paper by Kumar et al. In Transplant Immunology 2021 showed that more than 50% of alleles were unrepresented in both the panels. So many HLAs are not represented, donor HLAs are not represented in the SAP panel. One lambda has now introduced the further panel where they have more HLA class 1 antigens and HLA class 2 antigens. So this again further, if we already have if we have the knowledge of donor HLA, we can see whether this donor HLA is represented in the class 1 or class 2. Then only we should order further testing with this, because again it is a costly affair. The another thing that the antigen which is represent on the bead, sometimes it gets denatured, and that's why the epitope binding is exposed, and the sera patient present in the patient's blood may interact with the donor, not the donor, this antigen, denatured antigen on the bead, and give rise to the positive or false negative or false positive results. Whereas in the body, that epitope of particular antigen may not be exposed actually, even though the antibody, even if it is present in the patient sera, it may not react with the epitope as it is hidden. Sometimes while processing and making this SAB, the antigen is exposed on the bead, and that's why there we can have the false positive and false negative results. We should keep this also in our mind. Some more detail about C1Q. This C1Q screen is used with HLA coated bead mix to detect the complement binding anti-HLA antibodies which are present in the human serum. Just to give an example, here we can see that the C1Q is the first step in the classical complement activation, and it precedes the C4D deposition. So it simply distinguishes the antibody whether it has the capacity to activate the classical complement system or not. So it detects IgG1 and 3, which mainly activates the complement, and also IgM. So it to certain extent helps in determining the risk of AMR. So many times we see that the patient's HLA DSA is positive, but not all DSAs are actually detrimental. So this C1Q testing, it may help to identify the complement binding capacity. Just to discuss the example, this is the normal single antigen bead without the C1q testing, here we can see that the donor DQ5 was positive by single antigen. But on C1q analysis, this DQ5 was unable to activate the complement system as C1q is negative. So in such scenario, the donor DQ5 is actually negative. So in such situations, it is positive. Just to see the another, to look at the another example. Here, this patient was diagnosed with AMR, and this patient had the C4D positive in the biopsy, and the DSA which were identified here were DR753 and DQ2. This is normal SAT. But if we want to know which particular antibody to which antigen is causing this AMR, so this C1q antibody testing was performed, and here we can see that it is actually the DQ, which is antibody against DQ, which is causing the rejection. So to certain extent, C1q testing is helpful. Again, so further some issues with this app. Regardless of the strength of the alloantibody, without an antigenic target, the risk of AMR is generally low. So sometimes the expression of HLA on the particular bead is low. So it can give rise to false negative result also if the antigen density is not equivalent between the beads. Then there are certain scenarios where there can be the IgM interference. So this IgM positivity can be seen with the lupus patients. If the patient has the autoimmune disease, so in those patients, you can have the IgM interference. So if always try to give this history to your lab personnel, they can identify it if their baseline positive control is showing the low bead value, low positive control value. There is again a solution to it. This sera sample can be treated with the DTT or hypotonic dialysis solution, and in dilution, the test can be rerun. This is this was published in Transplantation 2016 that if the patient is having the positive SAP but negative flow crossmatch, this we routinely encounter. How should we proceed? Now there are 4 scenarios in this case. If whether there is a possibility of autoantibody. So if there is autoantibody, then there is a low risk. We can proceed ahead for transplant. The scenario can be that the DSA is positive with the low affinity or low avidity, but the flow crossmatch is negative. The risk cannot be stratified. So there is an uncertain risk. There is a possibility that the HLA expression is low on the bead or the lab factors. In all this scenario, the risk is uncertain. About lab factors, if we are sure, the risk can be low also. Now the different scenario, say the DSA is negative on the SAB, but you are getting the positive flow cross match. Now this is actually important. If flow cross match is positive, as we earlier discussed, and the SAB is showing negative, there is strong chance of Prozone phenomena. Again, it can be positive in case of autoantibodies, like in lupus and all. So if it is there, then low risk. If there is a Prozone phenomena is high, if your patient is having the history of sensitization, if his earlier reports like PRA was more than 80%, then think about Prozone phenomena. Risk is high. We should avoid the transplant. Similar situation is possible if the donor typing is incomplete or the donor is not antigen is not represented on the SAP panel. So again, here the risk is uncertain to high. And if the non-HLA antibody is there, you cannot predict the risk. So at uncertain risk. And it can be possible, as we just discussed, in case of the public epitope sharing, where there is because of distributive strength, the actual MFI is coming low. Now this algorithm is for DSA testing for candidates who are on the disease donor waiting list. So in solid phase assay, if it is negative, no anti-HLA antibody, we can easily go ahead for transplant. But for positive solid phase assay, we should know what are the unacceptable antigens for the particular patient, depending on the history of sensitization. So if after this, we should do the cross match or including auto cross match. If the final cross match is negative, then the DSA, there is no DSA, then there is the low risk. If the final cross match is positive, but auto cross match is also positive, it shows the patient has auto antibodies, then we can also again here in this scenario we can proceed. But if the final cross match is positive and auto cross match is negative, then we should consider the 4 or 5 different scenarios as just we earlier discussed, that whether there is any history of recent sensitization, the donor typing is incomplete, or the donor antigen is not represented on the SAP panel, or due to distributive strength to public epitopes, the antibody MFI is low, or the patient is having the non-HLA antibody like anti-endothelin or anti-mica. And we should avoid transplantation in such scenarios. These are the certain situations which we need to define as the exclusions. So if repeat mismatch with DSA is there, we should exclude bead any MFI, even if it is less than 1000, but because there is a chance of memory response to the same antigen. If MFI is higher than the threshold agreed with the clinical team, this is lab specific. But if MFI is low than the threshold, maybe less than 1000, but if your lab personnel is showing that it is sharing the common epitope, then you should be very cautious. And again, if you have the previous historic sera, which is showing that earlier this patient had high antibody, and here in this donor, even though today the threshold may be low, but then again, here again, there is a chance that the patient may have the antibody memory response and produce more antibodies post-transplant. Now, different societies have given different unacceptable antigen MFI levels. As per German, low risk is less than 3000, high risk is above 5000. In case of as per STAR, in sensitization transplantation, they have kept the level around 1000 to 1500 and above this as the unacceptable MFI levels. Now, even if you have the DSA negative, but there are certain situations where we need to perform the physical cross-match. These are the same as we just discussed, that if there is a presence of multiple DSAs at lower levels, because there is a chance of distributive antibody strength. If there is a presence of strong allele-specific antibodies, more than 5000 directed against the donor. If you do not have the recently tested SAP panel and your historic sera is showing positive, then again you need to perform the physical cross-match, that is the CDC and flow prior to transplant. And if there is any history of sensitizing event between the two testing, like blood transfusion or infection. This is how we proceed at a center. In case of live and disease, we do the typing of patient and donor. We do the mixed screening. If the screen is negative, we don't perform if the donor antigen is represented, we don't perform the SAT. If it is positive, we perform the SAT. And just before transplant, we actually do in almost all cases CDC and flow. About disease donor further, so after first testing, that is the DBD testing, when we come to know and the patient has given the consent and the alert is generated on the ZTCC, we get the HLA samples of the donor and we type it ABDRDQ. We don't perform DP routinely. And after the wait list is generated by the JTCC Nagpur, we perform the virtual cross match and this call is given to prospective recipients. With virtual cross match and SAP testing and this HLA, we usually get the results in 5 hours to 6 hours. And simultaneously, we get the CDC and flow cross match report. So if flow cross match CDC is negative and there is no previous history of sensitization event and DSA is less than 1500, we go ahead with the transplant. But if there we have the unacceptable antigen, history of previous transplant, and the DSA is more than 1500 and flow is negative, then with explained risk, we go ahead. But we always tell the patient that there is a fair possibility of post-transplant memory response and there is a chance of rejection. Now, how to start the lab at a new center? As we all know, we need the infrastructure place for this, equipments and instruments, then to run the reagents and the trained personnel, manpower. So these are the major equipments which are needed to start HLA or antibody lab. So as I am speaking here mostly of the antibody profile, so the machine which is required is Luminex, that is 100, 200 or 500. We can see in the up that the HLA typing by SSO method is also performed by the Luminex. So this same machine can be used for HLA typing by SSO method, as SSO method is sufficient for solid organ transplantation. The same machine, it is the major investment actually if we see. So the rough cost which comes around is 55 to 60 lakhs for this 100 200 Luminex machine. This 500 is a bit costlier, somewhere around 75 lakhs Indian national rupees is the cost which is for the lab scan 500. So this machine can be used for both HLA typing, PRA screening, DSA, and also for the MICA and C1Q testing. Along with that major instrument, this is Luminex 100 200. We need some of the small instruments like centrifuge, vortex machine, mini spin machine, plate, centrifuge plate shaker. So then they are not that costly. This is the in a snapshot how this is processed. So sera sample is collected, centrifuged, and this is then added to the plate. The sera is added to the plate and beads, then incubated and washed, and then it is read on the Luminex and results are interpreted on this Fusion software. So as we just discussed, something about sample criteria. This is very important for a clinician. We should take sample for antibody profile at least after 24 to 48 hours of dialysis. If there is history of blood transfusion, ideally the sample should be taken after 7 days of blood transfusion, if possible. In many cases, it may not be. We should prefer early morning sample with overnight fasting. In the morning, the patient can have the tea, cup of coffee or water is fine. Because if the patient eats something just prior to testing, the sera will become lipemic, and the lipemic sera will be persistent maybe for next 3 to 4 hours, depending upon the what food he has just taken. So it may interfere with the results actually. So to conclude, no single assay is perfect. A thoughtful process, including the knowledge of HLA system, cross-reactivity, epitope pattern, and the patient's clinical history should be employed to correctly interpret the data. I think it is actually very important to work closely with the HLA lab people to ensure the accurate interpretation of information and optimal management of patients before and after organ transplantation. Setting up an immunology lab is a costly affair, but it definitely improves the transplant outcomes as it improves the understanding. Questions are welcome. Thank you very much.
So, excellent presentation, Manish sir. I must congratulate you on the breadth and the extensive coverage and I'm very sure this is going to be viewed a lot of times on YouTube once once our channel goes up there and it's available. So okay, so at least let us start because we have a very little time left. So let me start by taking the questions from the chat box. So the first question is: does the current PRA assay available does it represent the Indian population? So is the antigen from the Indian population, like, I mean, there in the PRA beads that we are using?
That's actually a very good question. So the manufacturers, what they do, they take the most common HLA antigens present in the population. This is mostly manufactured in the Western countries. So not all population, antigens are represented in the screening, PRA screening. So that's why there is an option to check whether the donor HLA antigen is present in the tested panel, PRA panel. So we can check also whether it has been checked or not. So you can always inquire with your lab personnel whether it was checked or not, whether it is represented or not.
So basically, we have to do the donor and recipient HLA, and then maybe we can communicate with
Yeah,
the lab and find out.
yes,
So
sure.
most of these antigens will be represented.
Most of these are represented, but there are
Okay.
few papers which say around Indian population 30 to 40% alleles are not represented. So this one lambda has come up with the extended panel also. There they have increased the antigen around 40 to 45 in both class 1 and class 2. So
Okay.
the progress is being made that to include more and more antigens.
Sir, okay. And is there a suppose? Can you elaborate a little bit upon what is calculated PRA which is being used? Because I think that might benefit the listeners a little bit.
Yeah. So this PRA, we do actually two tests. The PRA, most of the times, what you get through the lab personnel, one is PRA screening, which where we give the report as only positive and negative. There you cannot have the percentage. And another one is the PRA quantitative. There you can have the particular percentage. So that particular percentage, it means that this number of patients, donors, with this number of donors, this patient will have positive cross match or the positive antibody against these donors. So that PRA, there is a percentage, maybe say for example 46%, 80%. So that means that particular patient, if his PRA is 46%, so this patient will have positive cross-match against 46% of uh, donors from that particular population. But in Indian context, as it was previously pointed in the previous question, that this PRA is not from the India. This PRA, these kits are all from the Western countries. So exactly it may not apply in this Indian scenario.
Great, sir. Okay. So oh, I have a few more questions to add. So you elaborated on the difference between the lab screen and the PRA screen. So is it based on only the difference in the antigen density, or is there some other difference? Because they are basically screening a lot of antibodies, and they're not specific to one particular antibody. So is the difference only
Yeah.
limited to antigen density, or is there something else or more to it?
Yeah, so there is a difference in PRA screening. The antigen which they make, actually, they collect the pool from 3 to 5 different individuals. In PRA quantitative, they collect the sample from single individual. So this is the difference, and the resolution is a bit better with PRA quantitative. And also in PRA quantitative, the number of antigens represented on the bead are less as compared to qualitative. That's why the density of antigen in PRA quantitative is higher as compared to PRA qualitative.
Okay, sir. And then, like you have nicely touched upon how that there is a distributive property of the beads, so that if there is a common antibody, it may get distributed on the beads. So, do you use this kind of a calculation while you are saying you said you do virtual cross matches manually? So, how do you do that? Because that's a common problem we are facing at our center also, whether to add them mathematically, or like how to work with them, or do you finally depend upon the cross match? So how do you use that data and like your knowledge of the immunology? So how do you interpret?
So, in our view, it just when you come to know that this is the shared epitope, and for that shared epitope, the antibody strength is distributed for particular antigens. So, you have just a fair idea that yes, this patient has some amount of antibody in the blood. Then, whether to proceed or not, again, it depends on the flow cross match. If flow cross match is negative, then with explained risk, yes, there is a possibility of increased risk. There is a increased risk of rejection post transplant, but does not amount that there will always be rejection, because as we all know, there is a limitation with the in vitro testing. Sometimes these antigens are denatured and the surface is exposed, while inside the body, the due to three-dimensional structure, 3D structure, these antigens, these epitopes are not exposed actually. Even then, even though the antibody is present, it may not cause the uh, rejection.
Okay. And sir, I think I have a final question before we can say good night to everybody. So, like you talked about doing the test in dilutions. So, how will that affect the cost of the testing?
So
That's
you
going
have
to
to
go up
actually,
substantially, right?
yeah, so that's so we have tested it twice in our lab, and we have to do actually a repeat testing. So you have to do the same procedure again. So the
Uh,
cost is actually doubled in a way. So same reagent, same, because once you have analyzed and you have the proper history, and then depending on the MFI values of the positive control, negative control, and looking at the history, if you think yes, there is a prozone phenomena, there was a prozone phenomena, or IgM interference you suspect, then you have to rerun again the whole sera. You have to dilute it. At the first step is the dilution only. So the cost is actually, the process is double. Now it depends on your lab, uh, how much they are going to charge, or just they are doing it on their own.
okay, so there is another question. So is the possibility of antibodies against shared epitopes raised by most laboratories, or clinicians or nephrologists should look for certain clues to this suspect? I could not get the question at all. Is there
No,
a
I
possibility of
think the Dr. Lowy wants to understand whether the labs will tell on their own, or we nephrologists have to share this concern. So this is actually important. We need to be in close touch with the lab personnel. And if there is a history of sensitization and you're expecting, yes, there is a fair sensitization history, then you should get an access to the software actually. The clinician along with the lab personnel should have the access to software to look at the epitope sharing.
okay. So what are the clinical indications to do PRA out of all the methods of HLA
It
detection? So
is
I think
just
I
a,
think
sorry, this is just
yeah, it is just a
a
screening.
screening test only.
And
So
also an
this is, yeah.
administrative requirement in some cases, like in our case in Gujarat, we are actually doing it for a administrative requirement. We are supposed to do that because based on that, some points will be awarded.
So
And
if
so
that
even
if doctor is saying asking about PRA quantitative, yes, that's the mostly is used for the point allocation only. And
yes,
if PRA qualitative, then it's a screening test. If no history of sensitization and nothing significant past history, then one can proceed ahead with the negative flow cross match and
low
CD.
cross match. Great. So with that, we come to the end of this webinar. And once again, I'll thank our secretary, Dr. Manish Balwani sir, for his excellent coverage. I mean, it's very nice. I learned a lot of things. I mean, about the nitty-gritties of the test. Thank you, sir, for joining in and preparing this extensive lecture. And hope to see you next time again with the next episode of this webinar and the transplant course. Thank you. Good night.
Good.
Good night.